Welcome to Auxanö Medical Podcast, where you grow in your medical knowledge. I'm Dr. Julius Kwedhi, and joining me today is my co-host, the always amazing Dr. Anastasia.
Hello, everyone. Great to be here.
Today, we have the distinct privilege of hosting Professor King, a renowned expert in complex endovascular aortic interventions. Professor, thank you for joining us.
Thank you for having me. It's a real pleasure to be here.
Today's episode tackles what many consider the frontier of endovascular surgery, fenestrated and branched EVAR for complex aortic aneurysms. So, Professor King, for our listeners who, primarily work with standard infrarenal EVAR, can you frame the clinical problem that these techniques solve?
Absolutely. The challenge we face is that approximately 15 to 20% of abdominal aortic aneurysms extend to or above the renal arteries, what we classify as juxtarenal, pararenal, or thoracoabdominal aneurysms.
Today's episode tackles what many consider the frontier of endovascular surgery, fenestrated and branched EVAR for complex aortic aneurysms. Professor King, for our listeners who primarily work with standard infrarenal EVAR, can you frame the clinical problem that fenestrated and branched techniques solve?
Absolutely. The challenge we face is that approximately 15 to 20% of abdominal aortic aneurysms extend to or above the renal arteries, what we classify as juxtarenal, pararenal, or thoracoabdominal aneurysms. Standard EVAR requires at least 15 millimeters of healthy infrarenal neck for adequate seal and fixation. When this proximal landing zone is inadequate or absent, we historically had only open surgical repair, which carries significant morbidity with mortality rates ranging from 7 to 16% in contemporary series. Fenestrated and branched EVAR evolved specifically to extend our endovascular capabilities into these complex anatomies while preserving flow to critical visceral vessels.
That's a substantial patient population. Can you clarify the fundamental difference between fenestrated and branched devices?
Excellent question. Fenestrated EVAR, or FEVAR, utilizes a main body graft with openings, fenestrations, strategically positioned to align with the renal and visceral artery ostia. We then bridge these fenestrations to the target vessels using balloon expandable covered stents, creating a seal while maintaining perfusion. The Zenith fenestrated device from Cook Medical is currently the only FDA-approved fenestrated device in the United States. Branched EVAR, or BEVAR, employs directional side branches, essentially fabric cuffs extending from the main graft, that are cannulated and bridged to the target vessels. This architecture provides more flexibility for vessels with challenging angles or when treating more extensive thoracoabdominal disease. The branches reduce ischemia time because the main device can be removed after deployment without compromising vessel perfusion.
Let's discuss patient selection and anatomic planning. What clinical and anatomic criteria guide your decision to proceed with these complex techniques?
Patient selection begins with the same diameter thresholds we use for standard EVAR, typically 5.5 centimeters for men and 5 to 5.4 centimeters for women, though we adjust for body surface area and comorbidities. The key anatomic factor is inadequate infrarenal neck length, generally defined as less than 15 millimeters, or hostile neck features including severe angulation exceeding 60 degrees, conical morphology with greater than 10% diameter increase, or significant thrombus or calcification.
What about anatomic planning? This seems extraordinarily precise.
It absolutely is. Planning begins with high-resolution computed tomography angiography with centerline flow reconstruction. We perform meticulous measurements, including aortic diameters at 5 millimeter increments from 20 millimeters above to 20 millimeters below the renal arteries, precise clock positions of each target vessel, angles of vessel origins, and distances from anatomic landmarks. Most centers use dedicated three-dimensional workstation software, The EVAR Assist Planning tool on GE Advantage Workstation is commonly employed.
Walk us through the actual procedure. What are the critical technical steps?
The procedure is performed in a hybrid operating room or advanced angiography suite with high-quality imaging, preferably with fusion capabilities. We typically use general anesthesia, though carefully selected cases can be done with regional techniques. Arterial access is obtained, usually bilateral femoral, with brachial or axillary access for branch devices. Large bore sheaths are necessary, often 18 to 24 French, for the main body delivery system.
What about technical success rates? How reproducible are these results?
The contemporary literature demonstrates quite impressive technical success. Multiple series report primary technical success exceeding 95% for both FEVAR and BEVAR. In the analysis by Mendez and colleagues reviewing over 890 patients who underwent fenestrated or branched repair, technical success was 99% in the non-prior EVAR group and 97% in patients with prior failed EVAR. The U.S. Fenestrated and Branched Aortic Research Consortium data similarly demonstrates high technical success with appropriate patient selection and operator experience.
Let's discuss the perioperative period. What are the major concerns immediately post-procedure?
The perioperative focus centers on preventing and recognizing specific complications. 30-day mortality ranges from 1 to 6% for pararenal and juxtarenal aneurysms and 5 to 10% for more extensive thoracoabdominal repairs. This compares very favorably to open repair, particularly in our patient population, which is typically older with multiple comorbidities. Renal function is a paramount concern. These procedures involve significant contrast load, often 150 to 250 milliliters of iodinated contrast, combined with potential atheroembolic phenomena and direct renal manipulation.
What about spinal cord ischemia? This is always concerning with extensive aortic coverage.
Spinal cord ischemia is indeed one of the most devastating complications, though rates are substantially lower than with open thoracoabdominal repair. In complex EVAR, the incidence ranges from 3 to 7%, depending on aneurysm extent. Crawford Extent 2 aneurysms carry the highest risk due to extensive thoracoabdominal coverage. Multiple risk factors have been identified: female sex, prior aortic surgery, coverage of lumbar arteries and hypogastric arteries, perioperative hypotension, and anemia.
Let's discuss outcomes data. How durable are these repairs long-term?
The long-term data continue to mature and are quite encouraging. The pooled analysis by Butts and colleagues showed 1-year survival of approximately 90%, with 5-year survival ranging from 66 to 77%, depending on aneurysm extent. Importantly, freedom from aneurysm-related mortality at 5 years exceeds 90% in most contemporary series. Freedom from reintervention at 1 year ranges from 85 to 90%. Reintervention rates increase with time. Approximately 15 to 20% require secondary procedures by 3 to 5 years, but the majority are minor interventions, such as type 2 endoleak embolization or extension cuffs.
As we conclude, what key clinical pearls should our listeners take away?
First, recognize that 15 to 20% of aortic aneurysms have insufficient infrarenal neck for standard EVAR. Don't miss the opportunity to offer these patients fenestrated or branched repair rather than assuming they need open surgery or are untreatable. Second, meticulous anatomic planning is non-negotiable. Invest time in precise three-dimensional measurements and device planning. The procedure's success is largely determined before entering the operating room. Third, nephroprotection is paramount. Implement comprehensive protocols, including hydration, contrast minimization, blood pressure optimization, and close postoperative monitoring. Renal injury is preventable in many cases with appropriate precautions.
Professor King, this has been extraordinarily comprehensive and practical. Thank you for sharing your expertise with our listeners.
Thank you for having me. It's been my pleasure to discuss this evolving field.
For our listeners, fenestrated and branched EVAR represent the cutting edge of vascular surgery, with excellent technical success rates exceeding 95% and significantly improved outcomes for complex aneurysm patients.
Thank you for joining us on Auxanö Medical Podcast, where you grow in your medical knowledge. Until next time, continue learning, continue growing, and continue providing exceptional patient care.